Hello, everyone. If you were able to join us last time, we did a intro to ARFID, and we close to finishing everything we had hoped to, but mm, we're we had a few more slides left over from last week, so we're going to continue briefly at the conclusion of last week as far as the interdisciplinary team, and then we will move into the next subject matter. So if you were with us last week, Dr. Jones spoke about the therapist's role and the therapeutic impacts that ARFID has, psychological impacts that ARFID has on people. And so what we also want to make sure that everyone is aware of is that in addition to the psychological impacts of ARFID, there's also medical and nutritional impacts. And they vary in intensity, in duration, and how many of these different symptoms appear. So I won't read all of these things on the slide, but really the thing to take away is that the medical and nutritional impacts of ARFID can be significant. Anything from fatigue to heart issues, bone density reduction, difficulty focusing, bone loss, electrolyte imbalances, low blood sugar, weight loss, or failure to grow. So we really want to intervene as quickly as possible to minimize these diagnoses or concerns and help provide healing to them as well. So last time Dr. Jones spoke about the role of a therapist. I want to explain a little bit about the role of a dietitian in treating ARFID. Therapists and dietitians, when working with someone with ARFID, have so much collaboration that is essential to help someone. And this is something that I just love about ERC that we get to do every single day because we're under the same roof, we're in the same building. We can hop up to each other's offices and chat to make sure we are providing that cohesive care. So some of the things that the dietitian will do is help someone identify disordered thoughts, feelings, and behaviors that are supporting the eating disorder, and then help to evaluate those current disordered eating patterns, and then explain and educate on the role of adequate nutrition and physical and mental health. And then this is the key, really developing an individualized meal plan to help patients establish a healthy eating pattern. And that individualization is just so important because each person has their unique presentation, their unique fears related to food. And so we have to treat them as an individual. And then the dietitian will work from that individualized meal plan and individualized treatment plan to help the person gradually challenge their food myths, their misconceptions, any harmful beliefs related to nutrition, such as like, this food will always make me throw up, or this food will always do this thing that they're scared of. And then we engage them in treatment. We plan out activities such as cooking, therapeutic meals, grocery shopping, depending on the age appropriateness of those things, to help them develop new behaviors, even maybe new skills. Some young adults that we work with just have had minimal opportunity so far in life to learn how to use those basic cooking skills in their residence. So we want to make sure that they have the ability to sustain themselves in a way that works for them. And then we want to help them work towards that acceptance of food-related tasks and environments. Maybe they're very scared to eat out at restaurants or eat out outside of the home at, say, a friend's house or for the holidays, and that really impacts their social life. We want to help provide those gradual exposures. And none of this is a surprise. Everything like that bullet point says is planned and planned with the patient. The patient is actively involved in the planning. We want treatment to not be done to them. We want them to be involved in the treatment planning. And then we can, as dietitians, model appropriate eating. So we'll eat one-on-one with the patient. We'll even take them out to a restaurant that used to be normal potentially for them, or work with them in therapeutic meal types of situations to help normalize those and have that support so they don't feel alone. And then we want to help our patients maintain neutrality and non-judgment regarding their food choices. We live in a very diet-focused, diet-centric world today, and there's so many messages out there in the media about food that it can be hard for anyone, eating disorder or not, to understand what is truly beneficial for my body when it comes to eating. And then as dietitians, we want to help patients understand how they're using their food, their weight, their eating behaviors to cope with stress and anxiety. That is one thing that all eating disorders have in common, is that their eating behaviors have become a coping skill to manage discomfort in their life. And so we want to help them make that connection with the support of the therapist. And then we want to help them eventually work towards resolving those disordered thoughts and feelings around food, body size, if that's a concern. And that definitely is a long-term goal. And I think something with ARFID too that can just feel challenging for patients, for caregivers, sometimes even for clinicians, is that progress can feel like it's happening very slowly. And that's to be expected, because what we're asking our patients to do is go towards these fearful food situations and start going through them versus avoiding them. So it can be very slow. It can be a 2 steps forward, 1 step back process. So we really want to look for those small wins and recognize it will likely take years to really fully heal from this disorder. So having that just perspective in mind, I think, can be helpful for anyone dealing with ARFID. So as far as nutrition interventions go, we want to gather data and work towards increasing their variety, improving their food intake over time. So there's a few different techniques that we can use. We often, as dietitians, will use things called a fear hierarchy, or food acceptance and fear hierarchy, where we're evaluating what patients feel are safe foods, what are like okay foods, and what are very scary foods. And then we start chipping away slowly and gradually as they express willingness to do so. And I think that's so key, is that we need the patient's buy-in to at least a little degree, because we don't want this to be, we don't want them to feel like we're doing treatment to them. We want them to be involved in the treatment and working towards owning the treatment and having that willingness to slowly go towards these scary situations. And then sometimes what we can do to help conceptualize things is put foods for that individual in 3 different categories, as like the stoplight would be kind of the symbol to think about. Red meaning super scary, nope, stop, I'm not going to eat those. Yellow being, I really don't prefer to eat them, but maybe on time to time, certain occasions, I might be willing. And then green are those, sure, like I'm willing to go towards those foods, eat those foods. So this is where we can really individualize treatment, because we're collecting that data that is specific for that patient and developing a plan to gradually expose them to foods as they're willing and able to do so. So what is the role of families and caregivers? They are just as important members of the treatment team as the therapists, doctors, dietitians, and other clinicians. And it can be hard. Y'all are oftentimes coming in and you've tried everything and you've done your very best. And this diagnosis is not your fault. You didn't cause it. It happened to your loved one, and here you are. And eating disorders just take really a village to wrap around and support someone through. So what we encourage families and caregivers to focus on is to support and validate your loved one. And even if you don't quite understand it, just trying to envision what it's like to be in their shoes. And even if you disagree with them, validating that I can see that you're scared and let's work through this together, even though in the back of your mind you may be thinking, why are they so scared about this food? And then collaborating often with the treatment team is absolutely vital. What we say oftentimes to our families here at ERC is that there's no such thing as secret keeping. Secrets keep people sick when they're trying to recover from eating disorders. So you as the family and caregivers tell us what you're hearing and what you're seeing. We're going to do the same. We'll stay in contact via the phone, email, consistent sessions, and really we're collaborating so much. So I always tell families, if you're in doubt, if you're like, I wonder if I should tell the treatment team this, the answer is always yes. Go ahead and share that information with us. More information is better than less. And then sticking with the treatment plan. And this, I think, can be a challenge sometimes because what your loved one is going through is hard, and they're scared, and it's not something they really want to do. Who would want to continue to go towards these scary things? And something I would tell patients all the time is that, hey, if we didn't have to go towards these scary things, we wouldn't. But what we know is for healing to occur, we have to slowly, gradually, methodically go towards these fear foods so that you have a more free life. And eventually that fear that you're currently experiencing starts to diminish and eventually go away. So sticking with the treatment plan can be hard because it can be very tempting to see your loved one in distress and go, okay, I'll fix it. We'll just give you safe foods instead of the plan for the food exposure this evening. And nobody's perfect. Nobody goes through treatment perfectly, patient, families, clinicians. So just, it's okay. Like we want to know what happened and we'll help support you through it. But sticking with the treatment plan as much as possible is so important because it shows the eating disorder that, hey, the family, the caregivers, and the treatment team, they're all on the same page here. We're all supporting the loved one and we are going forward together. And then maintaining a regular pattern of meals and snacks is super helpful. And this can be harder for families that are just used to being very sporadic, very kind of last minute planners. And there's nothing wrong with those things. Oftentimes we need those skills to operate successfully in this world today. However, while your loved one is recovering from this very significant disorder, maintaining a regular pattern of meals and snacks to the best of your ability is very helpful for that consistency. That consistency really can help someone kind of manage their anxiety more and help them know what to expect. Now, that being said, that doesn't mean you have to have, let's say, dinner every night at 7 p.m. on the dot, but maybe in general, you and your family work to say, okay, between most nights between 7 and 7:30 or 6 and 6:30, whatever the time frame that works for your family is, we will aim to have dinner. And that structure can just be very helpful in calming your loved one's mind. And then promoting the use of coping skills and really encouraging your loved one to use those. Something that sometimes our patients will say because they're just frustrated and they want this fear to go away and they want to be better. And who wouldn't want that? They'll say things like, well, these coping skills just aren't working. And they're not wrong, they're not lying, but sometimes coping skills take time to practice and repeat for them to really start to sink in. And an eating disorder behavior is instant gratification. It provides that self-soothing that is so powerful, that keeps the eating disorder in control oftentimes. So a coping skill is not going to be as effective initially as an eating disorder behavior currently is, but over time, the brain starts to rewire itself and they learn new techniques that they start leaning more on. And with time, that practice, coping skills become more helpful. So promoting the continual use of coping skills, regardless of what they're saying, can be beneficial. And then prioritizing your own well-being. It can be an exhausting process supporting someone through eating disorder recovery. So prioritizing your own well-being is essential. So working together as a family, getting some of your friends involved so that you can have that time for yourself that you need, whether that's to exercise, see a therapist, hang out with your friends, because your best self will be such a support to your loved one going through treatment. And then holding limits with the eating disorder is absolutely essential. Something that I've seen over and over during my years at ERC is those families who are able to really hold those limits, say the hard no's sometimes because it's in the best interest of your loved one. Those are the patients that get better. Patients who have families and caregivers who struggle more to hold those limits, their recovery takes longer because there's mixed messages that the eating disorder is receiving. And if the eating disorder is given an inch, it will take a mile. So holding limits early and consistently can be so, so powerful. So let's switch gears and talk a little bit about sensory sensitivity. That is one of the subtypes of ARFID. And Dr. Jones, I think I'm going to hand it over to you.
Awesome. Thank you, Jennifer. Yeah, so we wanted to spend time each week for the next few weeks really doing a deeper dive into each one of the subtypes and taking one subtype per week for the next 3 weeks. This week, we want to discuss the sensory sensitivity subtype. And really, we're looking to better understand as we go into these 3 weeks of deep diving. We really want to understand, or have you guys understand, the symptoms that pair with these subtypes, the function that these symptoms serve, and then what the treatment to address the symptoms look like, and kind of how we gauge progress towards recovery, what recovery looks like, because it can really vary quite a bit. There's no one definition of what recovery or recovered looks like for someone with these subtypes of ARFID often. So as we talk through this subtype, I want each of you to think about a food or several foods that you strongly dislike, maybe ones that you've tried before and have never liked, ones that you've had an aversive experience with, ones that you know about that maybe feel really scary, or you have a strong disgust response when you even think about eating these foods, and really keep these foods in mind as we talk about what it's like to have this particular subtype of ARFID. So we often get the question, how does somebody have this ARFID in general, but in particular with the sensory sensitivity subtype? This is one that often shows up very early in life, and we'll get questions from parents or loved ones who want to understand how their loved one with this diagnosis ended up with the diagnosis. Why do they have this symptom profile? So there's a variety of factors that we believe contribute to this particular subtype. And really, when we're talking about the sensory sensitivity subtype, we're talking about the development of taste preferences. There's a pretty wide continuum of what taste preferences look like for different people in terms of how limited they are in foods that they like or are willing to accept. There are people in the world that will eat anything and everything and are excited about it. And then there's people in the world who have this subtype of ARFID who maybe eat only a handful, 5 to 10 different types of foods that are very specific in their presentation. So we will tend to see that picky eating seems to run in the family. So there's believed to be some kind of biological and genetic factors that weigh into this. Really, tolerance around bitter taste and preference for protein foods is highly heritable. So if you have 2 parents that both tend to not really love vegetables and really struggle with foods that are higher in protein, it's very likely that the kids that they have together are also going to have those qualities. We also have this label of a super taster. If you guys have ever heard of this, people that are very sensitive to taste, maybe taste things that are not commonly tasted by other individuals, or maybe are more subtle taste, they can really taste them in a more obvious sort of way. And people who are super tasters are more likely to have this particular subtype of ARFID. They taste those small variations in types of food. So these would be people who often become very brand specific. They have a strong preference for, or are kind of limited in their ability to tolerate maybe certain brands of bread or certain brands of chicken nuggets, or maybe they can eat a burrito at one fast food restaurant, but not another one. And it's really just those small variations in taste and texture that they're able to pick up on that the average person who is not a super taster maybe wouldn't pick up on or wouldn't be sensitive to. We also find that picky eating is more linked to people who have more anxious temperaments. And so, if you are more sensitive from an emotional standpoint, you might be more sensitive from a taste standpoint as well. When we look at so all of those are things that are really outside of anyone's control, right? Like biological factors, genetic factors, temperament traits, all of those kinds of things. We really don't have a say. That's just kind of what we end up with as human beings. There are some things that there's a little bit more of an environmental factor that plays into this. So things like familiarity with different foods and cultural norms. So within certain cultures, even subcultures, there are some foods that are very commonly eaten and other foods that are not. Anyone who's lived in different regions, even within the United States, will knows what this is like to, we're here in Texas. Mexican food looks very different here than it might look in the Northeast versus the West Coast and other areas of the country, and definitely different than what it looks like in maybe Mexico or Spain or other places where it's similar foods, but is presented in a very different way. And so if you're used to eating certain foods within your culture, and then are exposed to different foods outside of your culture, it's more challenging to incorporate those foods for most of us. And then kind of looking at the variety of foods that you're presented with as a young child, a toddler, younger school age child, if you are exposed to a wider variety in early childhood, you may be more likely to accept those foods later on in life versus having a more limited flavor profile and variety at a younger age may make incorporating a greater variety at an older age of life more difficult down the road. Sort of speaking across the board, most people tend to have a greater preference for things like foods that are higher in fat or higher in sugar, just have a sweeter taste, and lower preference for foods that are more bitter, like vegetables. That's a very common pattern that we see, really, regardless of whether or not someone has ARFID. If you look at kind of typical kid foods and kid preferences, that's something that we will tend to see from an early age, and those ability to tolerate or develop a liking for more bitter flavors develops as people grow up and their taste buds and taste preferences change over time. There's also universal aversion to things, what they'll sometimes refer to as bits and pips in food. So when you think about babies that maybe start off on pureed foods and go to more solid foods, there's often this transitional period where there's maybe a puree with some chunks in it. And that can be a difficult transition for a lot of people with ARFID. Those bits and pips are things that have kind of a variation in texture throughout, are often very challenging for people to incorporate as well. And then kind of the last thing that I want to speak about is this idea of aversive food experiences. We will often, most of us have had some kind of aversive experience with a food or type of food within our lifetime, but there are people who tend to be sort of genetically programmed and sort of environmentally programmed to be a little bit on the pickier side or a lot on the pickier side, are more likely to come across these aversive food experiences. If you think about it, if your taste preferences are more narrow, there are more foods that could potentially you can encounter that would have a more aversive experience, where maybe you're encouraged or pushed to eat a food that you really don't have the ability to tolerate at that time, or you have a really strong disgust response to. And unfortunately, there's often really well-meaning family members that are kind of encouraging maybe a young child to eat some vegetables or eat a protein food like steak or chicken or something along those lines. And maybe the child or the young adult has a really aversive experience with trying that. Maybe they gag, or they're really overcome by these strong emotions that they have, and they end up having this aversive experience that becomes very difficult to reverse down the road. And so it's definitely not the fault of the well-meaning adult or support person who's trying to help them incorporate more variety. Especially if you didn't know that could be the outcome that happens, but that is something that happens on occasion, or more than on occasion, for some of our individuals who have this particular subtype of ARFID. People are really trying to help them with these wonderful intentions of trying to expand variety when they're younger, and they sort of unintentionally walk into this situation where the individual has an aversive experience, or maybe they gag and throw up on something. Nobody pushed them to, but they're getting brave and trying a new food. They gag, they vomit, or they just gag a whole lot and feel very nauseated after that. And then it becomes very difficult to reverse that. And so if there's many of those experiences, that can contribute to some of the limited variety that people might have later on. Jennifer, if you want to click to the next. Thank you. Okay, so sort of an additional way of looking at how these things develop. This is a formulation that is used in the CBT for ARFID, cognitive behavioral therapy for ARFID. We'll talk about this in greater detail in a few minutes. But when we think about kind of how all of these different traits pair together and play off of each other, we have this biological predisposition of greater perceived intensity of the sensory properties of food. So things like taste, smell, texture. That leads to negative feelings about food. Food tends to not be as enjoyable if you have this strong disgust response to food, or you're more sensitive to some of these sensory properties of food. And then you start to, so first of all, food does not feel as enjoyable because it's sort of like walking through a field of landmines. You don't know when you're going to land on a food that you dislike, or maybe there are lots of foods that you dislike and you're constantly coming in contact with them. And then you start to have these predictions about what the consequences of eating these foods might be, or eating in general might be. So this initial sense of disgust or fear, being more suspicious of unfamiliar foods, and this belief starts to generate of, I won't like any new food that I try, so I might as well stick to familiar foods. It's not worth the risk of trying a new food because the likelihood feels so great that I won't like it, or maybe I'm having a strong disgust response just being in the presence of this food. Maybe this smells really overwhelming, it looks a certain way that feels uncomfortable or triggers those feelings of disgust. And so there starts to be this difficulty approaching new foods or novel foods. We call that food neophobia. So with that, that leads to greater food restriction. So this tendency to stick to safe foods, familiar foods, avoiding all new foods, that's naturally going to restrict the food intake overall in terms of variety. It often can restrict in terms of overall quantity as well, but we're really looking at variety primarily with this subtype. So then when we have a restricted dietary intake, we have nutritional compromise that goes along with that. We may have weight loss that happens if you're not eating a wide enough variety of food. Maybe that becomes difficult to get adequate nutritional intake to maintain weight, to grow appropriately if we're talking about a child or an adolescent. We could also see sometimes weight gain as well if the preferred foods are more calorically dense, more nutritionally dense. Maybe there's a tendency to consume a large amount of those because they are very hungry. They're not getting enough nutrition in some areas. So they're making up for that for overall caloric intake, and that can lead to some weight gain sometimes as well. As well as nutritional deficiencies that can impact appetite or alter taste of food. That can really contribute to the restriction as well. So we have this sort of reciprocal relationship between some of these things. So the food restriction is in a reciprocal relationship with the negative feelings and kind of this belief that trying new foods is scary or dangerous or uncomfortable. So we're not going to do that. We're going to stick to the safe, familiar foods. We have this sort of, as you restrict foods, you're going to become more nutritionally compromised, which is then going to further contribute to restricting overall variety. And then that also, from a psychosocial perspective, limits opportunities for exposure. So if you're not going towards these experiences where you might encounter new foods, you're not going to have as many opportunities to see peers or parents modeling successful completion of some of these foods that you've been avoiding. Fewer social events around food where you might feel encouraged to eat things that you wouldn't have previously eaten, and reduced opportunities to learn about new foods. And if you think about parents who might be in a situation where they're parenting a child with this subtype, parents become really overwhelmed and kind of burn out on trying to help their kids eat new foods too, because it's such a battle to eat something new and expand variety in that way too. And so often parents kind of feel put in this position where they kind of just give up because the battle is so hard to fight to add in the new foods that they just stick to kind of the same familiar foods to make sure their child is eating enough. On the continuum of selective eating, that bottom line that's on here shows kind of a range of adaptability or changeability when it comes to picky eating or comes to incorporating new foods. We all fall somewhere along this. On the far left side, we're going to have normative eaters who tend to be pretty flexible, open to trying new foods. They're not going to like everything, but they're going to like most things. And then as we move towards the right end of that spectrum, we're going to move more into sensory sensitivity, subtype of ARFID, that middle line there. And that can range anywhere from low or mild degrees of adaptability or changeability, maybe people who never come into treatment or never really need a lot of support. They just kind of exist as pickier eaters in the world, all the way up to more severe presentations. And as you move into that moderate and severe range of sensory sensitivity subtype of ARFID, you're going to have much greater sensitivity to the sensation of disgust. And all of this is going to lead into different ranges of picky eating. So kind of with this is where we're finding that line between sort of normative picky eating that we'll see for a lot of kids, or maybe they don't eat a lot of vegetables, they don't eat a lot of meats that aren't, breaded and fried, but they are going to go towards cheeses and carbs and dietary fats and things that feel a little bit more fun or sweet or exciting. And then as they grow up, they're going to sort of age out of that or grow out of that type of eating into more normative variety of eating as that adults might have. Someone with ARFID is not going to grow out of their ARFID. They're sort of in this category of lower adaptability, changeability, more disgust sensitivity, more sensitivity to sensory aspects of food that is not something that just naturally goes away over time. And again, that food neophobia that we talked about earlier, that extreme fear or dislike of something new, really avoidance of going towards new foods, is something that we're going to see in somebody who has ARFID that is typically not as common with a child or an individual who is just a picky eater, so to speak. So we talked a lot about disgust, and I think it's important to talk through kind of the role that disgust plays in how this subtype of ARFID functions and kind of what we can predict it would look like as we move into the treatment piece. So disgust is one of our basic human emotions. It's why it's featured in the Inside Out movies. It is something that all of us experience, and often we have all experienced it in relationship to trying new foods. So like all emotions, disgust serves a really important function and purpose from an evolutionary perspective, and that's to protect us from poison and disease. If we experience disgust towards a food, we are more likely to not eat that food, which then helps to protect us against something that could be actually harmful towards us. What happens with people who have this subtype of ARFID is that they have higher levels of disgust and they experience disgust towards foods that are actually safe and would not create any harm or cause us any harm. So as we get to those higher levels of disgust, it becomes challenging to achieve this process called habituation, which is the weakening of the physiological response that we have to a certain emotion. So if we think about the emotion of disgust, we all kind of have this universal face that we make when we're disgust, kind of exactly what the picture shows here with the disgust character from Inside Out, wrinkling your nose, kind of scrunching up your upper lip, squinting your eyes. Like we kind of have this universal physiological facial response. We often tend to feel tense or nauseous or other sort of physiological things tied in with that. And as we habituate to an emotion, we see a weakening of that. With disgust, that's an emotion that really habituates very slowly. And the higher that level of disgust is, the slower it's going to habituate. And we may never get down to a place where there's no disgust in response to certain triggers. So if we think about kind of universally disgusting things like vomit, most of us are going to have a disgust response to vomit. Even the most seasoned nurse that sees it every single day is probably still going to feel a little bit disgusted by it. And that's a protective factor. We kind of want that. When this happens in the context of something like a safe food that isn't going to create any problems, that's when we run into issues with that habituation not happening. And then it becomes very, very difficult to incorporate new foods. And that just knowing that the disgust is so strong and doesn't go away very quickly, if at all, creates a lot of anxiety. So there's that initial experience of disgust that then triggers the subsequent experience of anxiety. And then that really generates a lot of avoidance in people who are experiencing both of those emotions at high levels. And it can make it really difficult for us to challenge those unhelpful beliefs tied in with the experience that's triggering the disgust and the anxiety. So we're going to move into talking about cognitive behavioral therapy for ARFID or CBT-AR. It's a manualized but very flexible treatment that we have. It was one of the first treatments available for ARFID, and it's one that we have really found a lot of success and incorporate a lot at ERC, and one that there's a lot of literature to support its efficacy at lower levels of care as well. So Jennifer's going to talk through the first couple of stages and kind of what that looks like as we're working through CBT for ARFID for sensory sensitivity subtype.
Right. There we go. Okay, so for stage one, the psychoeducation stage and that early stage of change, things that clinicians and families, caregivers can focus on are understanding, just like you are today, about ARFID and what ARFID treatment entails, starting to monitor food intake. No one recovers from an eating disorder in isolation, so it really is an all hands on deck approach. And so a lot of monitoring of food intake for the time being can be very, very important. And then, like we already talked about, establishing a pattern of regular eating and trying to stick to that. And it may feel like life revolves around the meal plan for a little bit, and that may be true. And a way that we view food in these higher levels of care and during treatment for an eating disorder is that food is a patient's number one medication, because no one with an eating disorder can get better without that consistent nutrition. So that pattern of regular eating is really, really important. And then starting to increase the volume of preferred foods is important, because especially if weight restoration or weight gain is needed, we've got to make sure that they're eating enough for that to happen. And because then their brain can continue to heal, and then their body can get back on their normal growth curve if they're an adolescent or a child, or get back to a better state of health if they're an adult. And then start to formulate what are those maintaining mechanisms that are really allowing the eating disorder to continue to exist, so that we can start to look at, okay, what is most important for us to address? And we want to start there. So a little bit further, like here's an example of what we mean when somebody at a higher level of care comes in and they're on what we call a meal plan, and they receive particular menus for ARFID because of their sensory sensitivity. We will create individualized meal plans where your loved one, or depending on age, if they're a young kid, you would pick for your loved one certain items. And you'll notice that some of these items on the meal ticket here are from outside restaurants, Whataburger, Chick-fil-A. Like we will get whatever we need to get food wise to help someone with ARFID. So if we can't make it on site because, like Dr. Jones was saying, there's a brand specific need because of that sensory sensitivity, we'll go and get Whataburger. We'll have it delivered every day to make sure that your loved one is healing. So we individualize menus, and we can continue to adapt them over time. And it's okay to rely on supplement. And what we mean when we say supplement are oral nutrition drinks, things like Boost or Ensure, Kate Farms, even sometimes chocolate milk. It's okay to rely on those types of things versus solid foods to help get someone's nutritional stabilization moving in the helpful direction. And really what we really recommend not doing is trying to hide food within other foods. It diminishes that diminishes that sense of safety that we're trying to build. So we really want to be transparent and not try to sneak in vegetables here or there, or say, oh yeah, it's a Whataburger sandwich, but we really made it, but we tried to make it look as close to a Whataburger sandwich. So we just want to be open, transparent, honest, so that they continue to develop that trust. And then as we go from stage one to stage two, we're getting more into the treatment planning now that some of the education's been done, some of the foundation has been laid with development of an individualized meal plan, starting to figure out therapeutically what are the most important things to address first. Other things that will go into the treatment planning are focusing on continuing to increase that volume of food. A lot of people with sensory sensitivity are just fearful in general of food, and they may only feel comfortable eating a small amount of their safe food. So we have to help them start to tolerate feelings of fullness and start to consume more so that their nutritional needs are met. And then over time, start to slowly increase that variety. So that can look like a lot of different things, and I'll show you here in a moment an example. And then in stage 2, we want to start preparing for what stage 3 is and help them start to select foods to just learn about. They're not saying, okay, I'm willing to try them. They're just saying, I'm open to talking about them and exploring them. So what's involved in stage 2 when it comes to treatment planning are a variety of different things. So it can look like exposures to new foods with different tastes or textures. It can be working on that disgust sensitivity and providing accommodations for that. It can be setting realistic goals to help just increase willingness to eat different foods and expanding that variety. And this is where it does take such an individualized approach, and we involve the patient in this experience because we want the expectations to be clear. We want them to know what to expect. We want them to know that we're all on your team here and we're all here to support you, and this is what it's going to look like. So where do you begin? There's so many different things we could address, and it's kind of a long road to the finish line of recovery. So where do we begin? Well, we can begin by just doing some behavioral observations. And I think this is where caregivers and families come in and play a very significant role because you've observed them day in and day out before we ever, as clinicians, got to know them. So your insight is so important. And then starting to ask, like, okay, this food, like the family saying, or maybe the individual that's in treatment is saying that, oh, I really want to work towards incorporating this type of food. But really then asking the question, is this new food essential to add at this moment? Like, where do we need to start? Just like somebody who's learning how to swim wouldn't start in the deep end. They would start in the shallow end. We want to start gradually and carefully and not have them face something that is just completely overwhelming or maybe just not essential at that moment. And then considering what types of foods is the patient currently not eating that they may need to function. Dr. Jones mentioned earlier in the presentation about protein. A lot of patients with ARFID may avoid a lot of different foods with protein. They're just not that preferable taste to them. And we know that protein is essential for an overall healthy body. So that may be a place where we want to try to aim first our focus to really help improve their nutrition status. And then asking, are there certain foods that they're really embarrassed by because they can't eat it or distressed by? Maybe it's a common kid food and all of their friends are eating it, but they can't eat it. So we really just want, where can we start that'll give us, in a sense, the most bang for our buck? So as we talked about a little bit earlier, we can start using some of these tools like fear hierarchies, categorizing foods into red, yellow, and green categories. So here's an example of a fear food hierarchy. This, by all means, is not the one and only food hierarchy that someone can use to really monitor for acceptance versus fear, but it really helps the patient or the family, depending on the age of the patient, identify what foods are completely free of fear in order to eat, and then what foods lead to extreme fear and avoidance. And it goes into different categories. What the snippet on the screen here is showing is different fruits, but then there's one for vegetables, proteins, starches, etc. So really just getting that really comprehensive understanding of what foods are acceptable versus not to that individual. And then we can start putting them in those different categories of green, yellow, red. So this is a sample patient, and this patient had an affinity for crispy, crunchy textures. Those textures were safe for them, but soft, slimy food textures were those foods that they would just avoid to a significant degree. So we are able to identify, okay, if this person needs to weight restore, we're really going to focus in on giving them initially a lot of foods from the green category and the yellow category, because we've got to improve their nutritional status first and foremost, while we start incorporating some of these more scary foods. And then we start chipping away at the orange and red categories. And that's where we'd start using those questions we just went through, like, okay, what in these more scary categories are really more essential than some others? So we conceptualizing and having a plan is so important in stage 1 and stage 2. All right, Dr. Jones, back to you.
I'm looking at the time and I'm wondering, we only have about 10 minutes left. I wonder if maybe we should save the last few slides for next week and we could allow some time for questions, because I saw a lot of really good questions come through in the chat.
Let's do it.
That's great. Okay, let me start off by saying we had a number of questions about the slides. We do have permission to share out the slide deck. So the slides will be coming your way. I also followed up about the presentation, the videotapes, okay, of the presentations. So at this time, what we'll do is you all as attendees will receive the links to the presentations, and then at some point we'll get the presentations loaded onto the website. All right. So I know everybody is over the moon about those answers. I am, for sure. Okay. So Michelle and Jennifer, did you all want to go through the chat, or did you want me to go ahead? I started jotting down some of the questions that came through.
Bethany, and I'm wondering if you maybe have, since you've been looking at it throughout, and Jennifer and I haven't been able to, if there's any that are like, there's multiple people asking the same questions, or any questions that kind of hang together, maybe we could start with those to address them.
Yeah, well, we've got a lot of individualized questions, so we'll just start. Okay, we'll go for it. So coming in from Connie, is the treatment approach the same when dealing with a small child, 5 years old versus teen or adults, especially since her child just really doesn't see anything wrong with eating the small foods he likes? Do you notice the recovery and become less fearful at a younger age? So I guess the real question is there a different approach, treatment approach, when you're dealing with a 5-year-old versus a teen or an adult?
Yes, definitely. I think regardless of the age, we always want the input from the patient or the individual with ARFID as much as possible. And a 7-year-old, just kind of cognitively and from like a maturity standpoint, is less capable of doing that than someone who is an older adolescent or an adult. I think also the goals are going to be a little bit different too. Our goals for what a 7-year-old eating looks like ultimately might look different, and kind of the impact that the eating has on a 7-year-old could look very different than the impact from a psychosocial standpoint, how it might look for an older person. Generally speaking, it's going to be more collaborative with someone who's older than a younger child. Younger child, we're going to be focusing more on kind of exploration, becoming familiar. We might use like different metaphors, and I'll talk about this next week, and kind of that the last couple of stages of CBTAR. But when we're doing sort of the food exploration, we're going to change kind of the goals to some extent, but sort of how we approach it versus like an older adolescent or an adult. Typically, they're more motivated to get better. They're often approaching treatment sort of more voluntarily themselves. And so it's going to feel a little bit more collaborative from their end, and they're going to drive kind of what those food exposures look like a little bit more than like a younger child where the parents maybe have more say, or the treatment team is pushing things a little bit more in one direction or another. It's a great question.
So helpful. Okay, if a person is not suffering from malnutrition and is getting the proper nutrients and all the necessary vitamins and minerals, but is struggling to eat a variety of different foods due to very strong preferences or sensory issues, is it really an eating disorder or a problem?
It's a great question. And there's two components to an eating disorder when it comes to nutrition. One is making sure that nutritional adequacy is there. And in the question, Heather, you were explaining that the malnutrition doesn't exist. So that is great news. The other part of nutrition is enjoyment and connecting with others and giving you that freedom to live your life. So we want to look at both. So what I would say is really investigating, thinking about, are these sensory challenges that your loved one's dealing with really interfering with life? Is it making it hard for your loved one to do enjoyable things or just normal things for your family? Is it hard to go on vacation? Is it hard for them to be in school? Is it hard for them to participate in extracurricular activities? Because then that could be a part of an eating disorder, or just disordered eating, or just a challenge in general that leads to less of a quality of life, because that's what we're going for, is the best quality of life possible.
Okay, and I think this question came in last week as well, and we didn't get to it. Do you have advice for a family with an adult with ARFID and a 4-year-old who's somewhat picky, but not more than is developmentally appropriate? I've read that exposure to too much for those who already have ARFID is really not great, therapeutically speaking. But let's see, mom, who also does all of the food picking, cooking, etc., loves variety, wants to eat different things and wants our child exposed to many different foods as well. How do I balance this family dynamic while trying to teach our child intuitive eating when dad struggles with an eating disorder?
Jennifer, I don't know if you have suggestions for kind of a normative child sort of in that context, but from my end of things, I think it's hard because you don't want the whole family's eating to be driven around just the person with ARFID, because that does negatively impact everyone else's eating experience. But then that adds in the complication of multiple family members needing multiple different types of food served at meals. Because dad is an adult, my first inclination would be for dad to really be responsible for preparing his own food and kind of planning his own food. That way, mom, you're able to focus on yourself and your child, and that kind of allows for your child to have more of that intuitive eating experience as they're younger, and more opportunities to be exposed to a wider variety of food that maybe matches more what you're eating versus what dad is eating. I would also strongly recommend that if dad is open to it, he get some sort of treatment from a therapist and a dietitian, ideally both, to help with his restrictive eating.
Yeah, I think it's for someone that is that age, 4 years old, seeing what parents do as far as food behaviors can be very powerful, and really modeling what you want for your kiddo to consume can be really important, and just normalizing that different people have different food likes, and then just taking it day by day.
Okay, my son restricts food only at normal meals, but binges his head off on snack food and other things like pickles and hot dogs. Does this behavior jive with an ARFID diagnosis, which he received from an eating disorder psychiatrist, though I have never felt that diagnosis fully represented his eating disorder?
It could, and it could be one of those types of presentations that falls more in the ARFID category, which stands for other specified eating and feeding disorders. And that is what we call a catch-all eating disorder diagnosis, where someone doesn't quite meet all of the criteria for ARFID or all of the criteria for one of the other eating disorders, but their eating disorder behaviors are still very significant and very much impairing a person's life. So that's where someone may be diagnosed with ARFID, in contrast to a different disorder. And so, I'm looking at this, just kind of thinking about the presentation, and the details about his age, height are super helpful. At 13, that is a younger adolescent. So, but yet 13-year-old Boys also tend to snack too, but this is where developing more of a structure with eating and working with the dietitian could be really helpful to normalize meals and normalize snacks. He can still eat pickles and hot dogs and such, but there's just more structure around that to really support him in developing and maintaining healthy food behaviors.
Yeah, and I think one of the things that we recommend for patients who do have ARFID, and something maybe to take a look at, is making sure that there's primarily safe foods. Like for someone who's growing and developing, especially who's pretty limited, we want to make sure they have a sufficient option of safe foods presented at meals where their whole meal isn't an exposure food or a food that they aren't currently able to eat, and really working on that at a slow, more graduated pace, kind of outside of like their meal plan requirements or what's sort of necessary for them to grow and develop. And 13-year-old boys are often going through huge growth spurts at that age, and both physically and in terms of brain development too. So I think making sure that there's enough of their foods that they're safe and comfortable to eat at meals, and that can help make sure that they're getting enough then, and could maybe shift to less snacking in between meals too.
Okay, we're at 12:01. So last question, are you okay with that?
Mhm.
Okay. My daughter is working through the CBT-AR program, but it's very closed off to discussing her feelings. Should we have concerns that we won't be able to move through the program until she opens up more and talks about her feelings? We are 5 weeks into the program and she is 7 years old.
Yeah, that's an excellent question. I would say, just generally speaking about therapy with 7-year-olds, most of them don't do a whole lot of talking about their feelings. 7-year-olds often lack or really are limited in their ability to recognize their emotions, verbalize their emotions, and really talk about those emotional experiences in a meaningful way. A lot of times at that age, emotions are coming out more in terms of behaviors. You might see it in play, you might see it expressed through art or things, sometimes therapists will use something like a sand tray activity. And really talking about emotions is not something that happens as kind of a core part of the CBT-AR curriculum. We're really going to be focusing in more on kind of the behavioral changes and talking about barriers to behavioral change, which may be emotions, but often aren't. And so just a kind of a quick answer to your question from my perspective would be that no, I don't think it's a problem that, only 5 sessions in that your child's not talking about her emotions too much. Definitely bring that up with the therapist that you're working with going through that CBT-AR curriculum. But really, it's such a long curriculum. We'll talk more about this next time, but we might be looking at like a whole 12 months worth of treatment if you're following the full CBT-AR curriculum, depending on kind of how quickly you're moving through the different stages. And so session 5 really is pretty early on for most kiddos, especially at such a young age. So I wouldn't worry about it too much at this point.
Okay, gosh, thank you all so much. And we had a number of great questions come in. I know we couldn't get to all of them, but please bring them back next week. And again, we'll get them in the chat and we'll try to address everything. Please keep in mind that everyone's different, and always refer back to your loved one's treatment team for specific questions or guidance, all right? Really want to highlight. So circle back to your treatment team and ask them these questions as well. So thanks so much, Michelle and Jennifer, and we'll be back on again next week, and we look forward to seeing everyone. Thank you.